The eczematous rashes are going to be a list of diseases that you're not really going to confuse from one another, but they all involve the word dermatitis, and they're all pruritic. So if you just take a top-level glance, you might confuse them one for another. But as you'll see, they're very distinct diseases, and there's just something you have to know about each one. Let's go through one at a time. The first is eczema, and it's actually called atopic dermatitis. Eczema is about the allergies. All right, allergies, asthma, and atopy. And this is the atopy part, the atopic dermatitis. You're going to see two presentations. One's in kids, one is in adults. Kids are going to present with this rash, flaking, scaling skin, and that itches in the eczematous fossa and at the diaper line. And you're going to see vesicles and crusts that look like impetigo. These do itch, and they're at the diaper line. So if only you saw was on the face, you might confuse it for impetigo, but because it's elsewhere, it kind of gives you the clue, oh, this is actually eczema. In adults, where it's been around for longer, it's more chronic, what you're going to see is symmetric lichenification. This is essentially long-term inflammation and scarring of the skin because of the scratch-itch cycle. Eczema is intensely pruritic, so the person just constantly scratches, and it tears up the skin. And when the skin tries to heal, it ends up being a bunch of scar. It's going to be symmetric, and it's going to be in the different fossa. AC fossa, the popliteal fossa, and on the extensors. The diagnosis is pretty easy. It's a clinical diagnosis. And the treatment is where you're going to score a lot of points. Because the number one thing to do is avoid a trigger. In kids, this is easy because it's usually a food, which is why we recommend introducing new foods only once a week. And the idea is if they get eczema after they've eaten that food, you remove that food from their diet. For adults, it's a lot harder because the trigger could be anything from the soap you use to the detergent to the type of stuff that's in your shirt. Right? So it's very hard to identify that trigger, but also once you do, avoidance is key to the treatment of the disease. If you can't avoid the trigger or you can't find it out, you can use emulsions. What this does is it reduces the itching. It breaks that scratch-itch cycle so you don't end up with lichenification. It doesn't do anything for the disease, it just makes the person better and allows them to heal. And last on the list that I'm going to give you is going to be topical steroids. If you do topical steroids, they can only be short-term because it leads to skin atrophy. There's other stuff you can do, but what I want you to learn is avoid triggers, then use emulsions for symptomatic relief, and if all else fails, topical steroids. Contact dermatitis is a board favorite because they can show you a picture just as well as they can describe it. For the pathology, I want you to remember type 4 hypersensitivity. You don't even have to know what that means anymore. Just know that if you see contact dermatitis, pick type 4 hypersensitivity. The patient's going to present in one of two ways. It's either going to be poison ivy. The person's hiking, they brush up against a tree, they get a pruritic rash, and wherever they scratch next, they end up getting that same pruritic rash. Or it's going to be a picture, the shape of an object. What I mean by that is they're going to show you a hand that clearly had a glove on. You can tell because their hand is red, right up to a clearly demarcated line where there was no glove. So it looks like they're wearing a glove of dermatitis. Or you'll see an image of a bracelet, but the bracelet's off. Or you'll see a picture of a foot where you can tell where the sandal strap was. Coming into contact with metals or latex is classic. This is a clinical diagnosis, and the treatment is to avoid the trigger. But sometimes you accidentally bump up against it, and now you have it. So for symptomatic relief, just like we did emulsions for eczema, you can use topical diphenhydramine to reduce that itching. This is not a life-threatening disease. It just itches. It's a pain in the butt. So if you can avoid the triggers, if you accidentally touch one, go ahead and give the anti-itch medication, diphenhydramine. Stasis dermatitis is something you're going to see a lot on the inpatient services. And it's always going to be a reason for the patient to have peripheral edema. What happens is that the skin gets stretched, and its response to being stretched over time is this. So you're going to find the person who has a condition which predisposes them to edema, such as chronic kidney disease, heart failure, cirrhosis, and they're going to have edema. Then their skin gets erythematous, and eventually it darkens. You let this go on long enough and you get those woody changes where it looks like tree bark. It's really firm, really hard lower extremities. And it's always going to be in the lower extremities because that's where the gravity pulls the fluid. The diagnosis is clinical, and very specifically, you should not biopsy this because they have poor venous circulation. If you biopsy and it's got poor healing, all you've done is created an ulcer. The treatment involves getting the fluid out of the legs. Diuretics can do this, especially if you're treating an underlying condition, or you can use things like compression stockings that push the fluid out and simply elevating the legs, facilitating fluid getting out of the lower extremity. You might mistake this for cellulitis. The reason being, if you see a lower extremity that's swollen and red, erythematous, you might think that's cellulitis. But if you've got bilateral, symmetric cellulitis, that's pretty impressive because that doesn't happen. Right? The legs aren't connected in any way, so it's not possible the same infection got both places at the same time. So if you see bilateral lower extremity cellulitis and they're not toxic, it's probably stasis dermatitis. They just haven't progressed to the hyperpigmentation point yet. And stasis dermatitis is going to be associated with the malleolar ulcers. These are called stasis ulcers because they have stasis dermatitis, they've got poor circulation, they end up with ulcers on the medial or lateral malleolus. Last is hand dermatitis, so called because it impacts the hand only. This is caused by too much hand washing. And it's going to be one of two people, either healthcare workers or food industry, food prep. Very rarely does the test give you a profession. So if you know you're in the dermatitis section and they give you the profession, you know what the answer is going to be. The thing is, what happens is that they wash their hands so much, they actually get a reaction. So it involves the hands only because that's what they're washing over and over and over again. The diagnosis is clinical. The treatment is to tell them to stop doing that. But some people aren't able to stop. But for those who can't, you want to use protective gloves instead of hand washing. And if you have to use hand washing, avoid harsh soaps. These diseases will not be confused one for the other. There's just a little bit of details you have to know in each one. That is the eczematous rashes.